Hi, welcome back. This is Chad Ezekiel with Help on Demand, and we're doing our second part of our Help on Demand live show with Jim Smallwood and John Newmeyer. So if you remember, Jim is President of Employee Benefits at Moody Insurance. He's a consultant for both small and large organizations on how they spend their healthcare dollars. Jim is also part-time a state senator and ranking member of the healthcare committee here in Colorado. So last time we got into some very good topics. We're going to pick it up where we left off last time. So we connected quality. We were on quality for a second there. I wanted to talk about that for a second. And it's a very far-reaching, it's not the longest word, but it's certainly, it's a big one in healthcare. So how have you seen people leveraging, say, either data sets that we were talking about before? How are we using that, say, in government or other policy to, to affect cost? Because at the end of the day, quality drives cost and outcomes and all those things. Seems like it's really important. So maybe we start on the employer side and we can work into how we might use that for policy and other things.
Yeah, I would say on the commercial side, in the private sector, we're seeing kind of a back to the future shift that is somewhat analogous to what's been done in government for a long time, which is really changing that motivation for the physician or the facility as to how they get paid. So this whole world of discounted fee for service that I started in my career, and you probably did as well. Sure. We started in a discounted fee for service world. We quickly moved into some sort of more capitated risk sharing type of world, which imploded on itself.
HMO days in the late 80s and early 90s. Yep.
Exactly. We saw those implode, move back to a discounted fee for service model by and large. And now it's just, again, in the last couple of years, we're seeing yet another shift back towards really the bigger mentality that government has had for a while, which is let's get folks connected with the correct high quality primary care so they know where to go, whether that's a relationship with a human being or a relationship with an app where they can tell, okay, it's been this long since I've got my blood work, it's been this long since I've seen a physician, it's been this long since I got my meds refilled, that I'm supposed to be on. So now that we're moving back in towards that model, first of all, we've seen cost reductions clearly over the discounted fee for service models in doing that. And, taking kind of a page out of the government's book as to, here's the world of realistic costs based on what we're seeing across the country. Here's what's fair. Here's what's obviously not fair when you don't have a choice. Right? Like nobody wants to walk into an ER thinking it's going to be $2,000 and find out that it was $12,000, right? When an ambulance brings you there, right? So there has to be some level of fairness brought into that, right? And then I use 12,000. What if it was 312,000? I mean, I think most of us would agree. Well, that doesn't feel fair. So it's kind of the intersection of all of these things, and it is really truly a back to the future model, because most employers that we're talking to, where they can geographically, are at least entertaining these, whether you call them a high performing network, a narrow network, a skinny network. The theory is still the same, which is we're going to concentrate your care with people who are not just looking to get as many procedures done as they possibly can, a provider or physician or facility, because we know we're getting paid on each one of them. Different payment model that I think is, if not the way of the future, it's certainly the way of the present.
Well, it seems to make sense in a lot of ways in that we've gone down a path. We talked about that path a little bit. It was capitation and fee for service, but we also had the consumer out there. We gave the consumer money through an HSA or HRA, and they would run around and make choices themselves. And there will, I think there will always be an element of that on some level, but also we know that these same analytics and AI that we're using today around quality allows us to pick those partners that do align on cost and quality, and that just drives a better overall cost picture, better outcomes, et cetera. So, and then in place of service too, we can use technology to get people into the right place of service, because excuse me, there's a optimal place of service. You don't want to to your point before, you were sitting at the golf course getting an eye exam. That's a great, it worked out great.
Yeah.
You don't need to be in the ER for that. So anyhow, it's exciting to see what's going on. I think it'll be fun to watch evolve, because I think we're heading in the right direction with a lot of things.
Yeah, and it's I'm glad you brought up these reimbursement type programs, because the conventional wisdom for a number of years, now approaching a decade or more, has been, well, let's put the patient in control of their care financially, and they'll make the right decisions. They'll take generic drugs when available. They'll go to primary care instead of a specialist. They'll stay out of the ER. And I think you phrased it perfectly, because for a lot of people, that is true. For folks like yourselves, that are pretty savvy in the world of healthcare, you would know to ask if there's a generic drug available, or to really maybe use AI to say, should I be going to the ER? Is this indigestion or heart attack? But for people that don't live and breathe healthcare, for the people that have, other jobs across our economy, this is a foreign language to them. And to assume that, well, since we put you in control financially, you're going to make the right decision, not just financially, but to make sure that you're getting the optimum level of care, hasn't really proven to be a reality for everyone. So I like this kind of dual option, dual choice mentality that I think a lot of employers are starting to adopt now, which is, okay, for folks that are very comfortable figuring this stuff out, or have figured it out, and you want to be able to potentially benefit financially through HSA, HRA, something along those lines, that tool is out there for you. But guess what? For the rest of us, it would be really nice just to put this in the hands of, I don't know, the people that do this for
primary
a living.
Care, primary care physician,
right? And have them guide the care, make it affordable along the way. Very low or no cost primary care physician, very low or no cost televisits or urgent care visits or generic drugs, and really make it attractive for people to say, look, maybe I should go get that checked out. This doesn't feel normal, and opposed to, oh my gosh, I don't want to come out of pocket $1,000 or $3,000. It's a $5, $10, $20 office visit. I'm going to go ahead and do that.
I'm sorry. I just wanted to say real quick. I saw firsthand when I was designing products to put out in the market. I always used to use my lovely wife as a case study, and I'm going to get in trouble for saying this.
Right.
I know, but it just shows, if you're not in the middle of the business, if you're not in the middle of understanding how to access care and where to find value, it's a very complex world. And so I tend to agree too that, moving, getting a primary care physician and getting a good relationship with them, they can help you make good decisions. So it's just
and putting it into the hands of the average person, it's an emotional thing, right? It's like, oh, well, my son fell down. I need to go right away to the emergency room. So you're not using logic, right? You're going to wherever you got to go to solve it, to only find out you went to the wrong place,
right?
Cost wise. So, and emotions are involved in purchasing products. I think people that have used their health insurance, a lot, pretty savvy, right? They know, gosh, if I do this, it's going to be a copay of this or a deductible of that. When you look at the types of, small, large group, self-funded organizations, I know several years ago, it was more inexpensive, for example, for an employer to say, look, I'm going to bump your compensation up and you go buy your own individual plan because it's cheaper than it would be to be in a group plan, which is contrary, right, Chad, to what we're all used to. What are you seeing now? Are you seeing maybe more people saying, I'm going to do a self-funded plan, for example, because, maybe I have younger employees, we're not utilizing that. Are there trends now? Because I know that changes over time, but current day, where would you think, Jim, that is?
Well, the percentage of employers choosing self-funded plans, at least here in the state of Colorado, I haven't looked recently at national statistics, but in the state of Colorado, it's extremely high. And I want to say the number is now over 50%
that are
of
doing
new
self-funded
purchases are into self-funded plans for a number of reasons. I mean, plan design flexibility, to be unencumbered by specific state laws and trying to cobble together something. If you're a multi-state employer, for example, the data that you receive, right? So we can help employees who are maybe struggling with everything that we've talked about, point them in the right direction. So to get that aggregated data and the chance to be better off financially. If you've got a group, John, exactly as you mentioned, who demographically speaking, or because of good luck, just doesn't use a lot of healthcare, there's a way to benefit in those. So we're definitely seeing an enormous rise in employers who are choosing self-funded plans and of carriers who are offering self-funded plans. I mean, the thought again decades ago of a large national carrier providing a self-funded plan to a group of 10 employees would have been laughable. And again, that's not that long ago. Whereas today, it is definitely the norm to be having those conversations. And each state's going to be a little different based on the players that they have, the state laws that they have in place. It's harder to purchase a self-funded plan in some states where stop loss requirements are higher. But we're definitely seeing a move towards it. There's no question.
So let me ask this question then, Jim. So where do you think it's all headed from a public policy standpoint? So that's a big question. There's a lot out there, whether it be Medicare for all, continuing down kind of the path we're on. There's a whole continuum of options. So what's your sense?
Yeah, it's the $1 million question, Chad. I mean,
more
because,
than that. It's
right?
the trillion
$1 trillion
multi-trillion dollar question.
Yeah, I mean, because you've got to look at the mentality of folks who are pushing for some sort of single payer system because they've had it, right? They're looking at premiums and out-of-pocket costs that continue to increase at a level higher than inflation every single year, because of and I'm not going to beat up the Affordable Care Act, because there are tons of things in there. I'm on the record multiple times saying here's all the good things that happened within the Affordable Care Act: metallic tiering, for the patient, MLR for the employer. I mean, there's a ton of good things. But the big kind of fatal flaws I see in that program is it put the worst possible person I can imagine in charge of your healthcare, and that's your boss. Right? Because any employer that has over 50 employees, their boss is required to give them health care. And once they do that, that's your health plan. So it takes away, you talked about people like wanting to shop for themselves and all of that. Well, a lot of those tools get taken away once your boss does what she is supposed to do or he is supposed to do and provide you the plan that's become your plan. So I think that's driven partly some of this. People get frustrated because they're not able to make their decisions by and large. Their boss is making the decision as to what kind of health care they get. And then they're looking at the costs, both coming out of their paycheck or the checks that they write, plus their cost to go and get services, saying, this is unaffordable. I can't keep continuing to do this. So I'm very, very sympathetic for people who want something different, but I'm also extremely nervous as the nephew and a grandson of people who have died in healthcare systems in Europe that I felt were unnecessary deaths. Seeing the care that they got or didn't get, the lack of choices that they have, and to imagine us in a world like that where, okay, you've got a cancer that's been deemed incurable by physicians that you've seen here in the state of Colorado, and you want to go to MD Anderson, but you can't. Because the system doesn't allow you to do that. Facing that decision terrifies me. And it's one of, I think, the best things that we have in this country is the ability to say, no, I don't want to do that. I want to have the flexibility to cross state lines and go where I feel I'm going to get the best care. So somehow we've got to figure that out. There's been tons of steps made, and I could literally take another hour to say, okay, at least here in the state of Colorado in the legislature, here's the dozen things that we've done in the world of transparency, in the world of creating boundaries around what's fair and not fair, in the world of usual, customary, and reasonable, and what you can be charged. So there are lots and lots of steps that can be taken and have been taken. Well, Medicaid expansion was one of the biggest ones. I mean, a state like Colorado adopted that, a lot of other states didn't. But there's a lot still to be done, and what intrigues me the most about the technology that you've got is I think it's one of the better tools that I've seen that can help guide I don't even want to use the term layperson, just somebody who's not an expert in healthcare, guide them down that continuum. Should I be on Medicaid and do I even qualify?
Mm-hmm.
If I don't, can I purchase a program and get those huge cost sharing reductions and advanced premium tax credits? Oh, I don't qualify for that. Well, is there some advanced premium tax credits? Oh, no. Well, then is there a way for me to get any insurance that's going to cover my pre-existing conditions? Because Americans still feel like insurance companies don't cover things.
Exactly.
Yeah. Oh, yes. I mean, just something to guide them down that path where, again, if you don't live and breathe healthcare or health insurance, this is complicated, just in the state of Colorado.
Well, and in Colorado, and certainly other states in the situation, but you have such an influx of people from out of state moving here, right?
Yeah.
So I now move into the state of Colorado. My son needs a pediatric oncologist. I can go on Google and search, but it's confusing. And, that's where technology to me says, okay, I need it in this area. Here's the type of physician or care that I need. And how do I find that? And so, you mentioned with our technology of doing those kinds of things, I can now go in, say, drop down menu, I need a pediatric oncologist in Lone Tree, put the zip code in, drop down menu, click on it, and up pops. And now I'm talking to that office through technology in seconds.
Mm-hmm.
And so that to me is the exciting thing of the future. You touched on a little bit in Colorado. What are some I know in government, there's probably not anything that's a neat, fun thing that's popping up, right? Because there's different challenges. But anything that you guys are all talking about that's kind of exciting in the state of, things that, we always think of government as negative, right? But, there's some great opportunities. Do you have any off the top of your head, just some cool things you're working on or whatever?
Yeah, it's a little mixture of both, right? So there are tons of things that are nonpartisan because healthcare policies, generally speaking,
thank goodness,
nonpartisan,
right?
So there's that, but then there is simultaneously the battle with what I would call the Medicare for all folks or Medicaid for all folks, if we're talking in the state of Colorado, that are convinced that government does things better than anybody else. So it's been a mix of a real partisan philosophical battle as to whether you should control your healthcare or whether the government should control your healthcare, which very little middle ground there, quite honestly. But then there's this whole slew of, again, nonpartisan things that we've done in the state of Colorado. Transparency is the big one, right? It doesn't matter how far left you are or how far right you are. Everybody feels that if you're going to buy something, you should know what it's going to cost, right? Yep. Other than healthcare, where else do you go and purchase something without having any idea at all if it was going to cost $400 or $400,000, right? You have no idea. So a lot of work around transparency, both from primary care, right? Primary care and the role that they have to play in providing this transparency. In Colorado, a lot of it was around freestanding emergency departments. Where people were walking into an ER thinking it was an urgent care, thinking it was going to be a $200 charge and it was a $2,800 charge or a $4,800 charge. So there was, I think, very good bipartisan, bicameral legislation passed in Colorado just in the last 4 years that shined a huge spotlight on that. I would say the last piece that, at least that I was part of, really proud to be part of, was this conversation around when a physician or facility is out of network and there's no contract in place, how much can they charge?
Yeah.
Because in a lot of states, really the answer is whatever they feel like charging. Which again, if as a consumer, you know what it costs and you want to pay a whole lot more, I have no problem with that. And a lot of my colleagues don't either. But the idea of, the ambulance took you to this place while you were unconscious and you woke up, and because it was out of network, they literally could charge you whatever they wanted, didn't feel right to anybody. So we were able to, in Colorado, to put some realistic boundaries around that to say, look, yes, you're out of network. Are we going to force you to be in network? No, we're not going to do that as government. But can you charge $1 million for an office visit? No. That's not fair. It would be analogous to finding out your car got towed away, and for you to go get your car back is going to cost you $50,000.
Yeah.
Right? I don't care what party you're a member of. Nobody would think,
It's not right.
well, that's free market. That feels good. Right? Nobody would say that. So there's
Yeah, first you have to find your card.
Yeah.
right.
Yeah, well, that's interesting. I think that's important. That last piece around out of network claims and things of that nature, and what you can really charge as reasonable is a big deal. I think there will continue to be, as long as it's allowed. There'll be people that make that a business model, right? There are providers, and whether it be physicians, et cetera, that's how they tend to make their living. So that's great to hear.
Yeah. And one final point on that, I'll say that's really interesting, that only being involved in kind of the legislative mix of this illuminates is, when you see these really high out-of-network charges and things that just don't seem logical at all, a handful of times when you sit down and talk to providers about it, the arithmetic looks something like this. What we do costs, I'll make up its numbers, what we do costs $5,000. We have so many Medicare and Medicaid patients that need this service that costs $5,000, but we only get $800 when we perform it. Therefore, when one of us walks in and needs it,
And
even
has
though
insurance.
even though it only cost $5,000, we lost so much money on the vast majority of patients that receive those services. Now we have to charge you $45,000 for that $5,000 procedure in order to make the arithmetic work. So that's something, again, you would have never thought of before. You would just look and say, oh my gosh, they're charging $45,000. That's ridiculous. We know that only costs $5,000. Well, the math actually works around it in a really perverted kind of way.
Yeah. How, going back to your business, if it's probably kind of a little bit of those people listening and they're struggling with how to make those decisions, how would they get a hold of you? What kind of things sets your firm apart maybe from some of the other firms in your mind?
Well, I always appreciate that question. As an organization that's always looking to grow. So I think here in Colorado, like in a lot of states, and certainly being in the Denver metro area, there's a lot of good alternatives when it comes to picking a consultant. But I think a lot of the stuff that we talked about today should be sort of the checklist of, okay, when I'm looking for somebody that's going to help our business solve as best as possible the healthcare puzzle, the employee benefits puzzle, what are those tools look like? What do they look like technologically? What do they look like just really from a lifestyle and experience perspective, right? Do you want to work with somebody who's done this for 30 years or somebody who's done this for 30 weeks or 30 days, right? Because there's very little barrier to entry in the employee benefits business. So kind of the experience, expertise, what do the teams look like, right? So if I decide to take that rare 2-week vacation, one of my clients needs something from somebody, what's the supporting cast look like? What's the team look like?
Sure.
And are they going to be there to help me? And then all of the resources, right? And again, I keep talking about table stakes. What do you have to have? The fact that you have to have great employee benefit or ERISA attorneys, that you work with great HR tools for those HR staffs, all these technology platforms that we talked about, whether it's open enrollment, employee communication, or analytics. And it's becoming a pretty interesting checklist of, hey, these are what the best firms in the country do just as the price of admission, and are the people that we're working with or the people that we're considering working with, can they go down and check those boxes?
Okay. I want to have some fun here for a couple minutes anyway, and talk about AI and how we think it might impact healthcare in some way, right? It's so it's on the news nonstop, and I think we have an opportunity in healthcare, maybe to reduce costs, maybe make better decisions, et cetera. But let's talk about AI for a second in healthcare. I think I'm aware of some companies out there that do a lot, use it for diagnosing, right? So you really work through a detailed system of questions to get to a diagnosis. So I think that's exciting. I wonder if you had any comments or any thinking around that or another spot in healthcare?
Well, I don't think a lot of what we talked about today doesn't start unless you have technology,
Totally, yeah.
and AI just makes that better,
Yeah.
right? It's one thing to give a health plan member some data as to where they can go to get care.
Yep.
It's very much a different thing to have them, as you mentioned, go down this checklist of, do you have this? Do you have that? How are you feeling about this and this?
Where do you live? Right. Yeah.
Right.
Yeah.
And then be able to really dial in the right amount of care, perhaps even to John's point, to the right person in our area, because this is the person that's closest to you with the most expertise and the highest quality,
Yep.
and maybe also the lowest cost.
Yep.
Right. I mean, that takes a tremendous amount of technology. I mean,
and bringing, sorry to interrupt,
please
but
do.
bringing different databases together, right? You have like a symptoms database connected then with some questions about the community or environment you're in, which impacts that an awful lot. Place of service, it's just quality. It really just is kind of dizzying when you start to put all that together.
It is. And, for when we're talking about medicine and the science or art of medicine, I think it's a little bit more challenging, right? If we had an MD sitting here with us, he or she would probably take real exception to the fact that, oh no, we're going to design a software program that will
To replace
completely
you.
replace you. But I do think that from a starting point, especially when you look at things like dental care, routine dental care, vision care, routine vision care, preventive care types of things, where we're not doing, the diagnosis of some acute rare condition, but it's just something that people use all the time. Oh, you need an eye exam and you need glasses. Okay.
Mhm.
What kind of glasses? Bifocal, trifocal, progressive? Okay. I mean, it still takes a pretty sophisticated level of AI to be able to guide people into some of these even most basic decisions. Who's close to me,
Yeah.
that's in my plan, who's affordable, who does this a lot. LASIK, I'm in the middle of looking at that for my oldest child. What are you going to do? To John's point, are you going to Google that?
Well, I see a lot of people using Facebook groups for that.
Isn't that
Yeah.
amazing?
Your community Facebook
Right.
group
Right.
seems like a good spot.
They're all registered physicians.
Right. Definitely.
Yeah. So it's amazing how far we've come, and it's amazing kind of the velocity that we're getting to provide such great data, such great tools to the members to, again, have them navigate something that's really, really complicated.
I think that's a great word to describe it. I think velocity is going to, it's going to be fantastic to watch over the next 20 years or less. Yep.
Right? 20 months.
Yeah, 20 months. Yeah, 20 months. 20 years turned into 20 months.
Right.
Jim, I want to thank you for your time today. It's been fantastic to talk with you about your very wide and deep view of healthcare and technology. It's been fantastic. John, always a pleasure
Thanks.
to
Yep.
be
Thank you,
here
John.
with you.
Too.
So I want to thank you very much for joining us today at Help on Demand Live. Thank you.